Welcome to our attendees who are just joining us. We are going to give a few minutes for everybody to join, and then we'll get started for our webinar Wednesday on advancing age-inclusive health systems. Thanks for being here. Okay. Well, welcome everybody. Thank you so much for being here today on our webinar focusing on advancing age-inclusive health systems. My name is Sarah Steenhausen. I am Deputy Director for Aging Policy, Research, and Equity at the California Department of Aging. I'm sitting in today for our wonderful director, Susan DeMorris, who is very sorry she couldn't be here. She's at the Millikan Global Conference on Aging and is looking forward to watching the live recordings of this when it's available. Before we get started, I just wanted to let you know that we will be having this live captioned streamed through the webinar in Zoom. We have, as you know, our American Sign Language interpretation as well. And all of the recording slides and transcripts will be posted at the Cal HHS Master Plan for Aging webpage and on CDA's YouTube channel within 5 days. Next slide, please. So we really encourage all of you to be engaging with any comments and questions you have. The chat function is enabled. So first, we'd love to hear from you, who you are and where you are, what organization you are with. And then if you want to send any thoughts or comments for everybody to consider throughout the presentation, please feel free to do so in the chat. Or you can also post questions in our question and answer box as well. For those joining by phone, and if you want to raise your hand, you can press *9, and the moderator will announce the last 4 digits of your phone number to unmute your line. So we're really looking forward to a really engaged discussion today, and we will open up after we walk through the agenda. We will open up for Q&A during our panel discussion. So next slide, please. So I'm really honored to be able to open up today's webinar and just kind of set the table for why we are here. The Department of Aging every month has been producing a webinar Wednesday. And the purpose of this is to delve into different policy and program issues that relate to our master plan for aging, but that we would like to highlight, particularly as we consider our next iteration of the master plan for the next 2 years. So we are using these webinars as an opportunity to hear from you, to get your input on different and emerging issues so that we can be most informed as we think about the next phase of the master plan for aging. So we really appreciate everybody being here, and we're particularly pleased that we are joined by the Commission on Aging. California Commission on Aging is a key partner of ours, and they are co-sponsors of our Wednesday webinar. So now at this time, I'd like to turn it over to my colleague, Dr. Janet Frank, who is both a member of the Commission on Aging and faculty with the UCLA Center for Health Policy Research. Welcome, Janet. Thank you for being here.
Thank you. Thank you, and welcome everyone on behalf of the California Commission on Aging. We are thrilled to be here, and as many of you know, by statute, the Commission is the principal advocate for older Californians. So we're very excited to be joining the webinar today, and we actually have been working on a number of fronts to really address issues around advancing age-inclusive and integrated health systems, which I'll tell you a little bit more about now. I mean, in a little while. But for right now, we just want to say we're glad to be here, and we're very excited that the CDA is leading these webinars. Very important topics. So thank you.
Thank you so much, Janet. And I think that's a great segue into what we're really going to focus in on today. And goal 2 of the master plan on aging focuses on optimizing health and quality of life through the health reimagined goal. But realizing this goal includes ensuring equitable access to services across the continuum of care and building out best practices such as age-friendly health systems and geriatric emergency departments, as well as others. So what we're going to do today is have an in-depth conversation with leading experts representing the field of medicine and policy and philanthropy. And we're going to discuss the best practices and opportunities and recommendations for how we in California can advance this concept of an age-inclusive health system. So what we're going to do, if you could go to the next slide, I'm really pleased to introduce my colleague, Dr. Laura Mosqueda. Dr. Mosqueda is a real leader in this area, in this field. She's a professor of medicine and geriatrics at the Keck School of Medicine. She's also a 2022-23 Health and Aging Policy Fellow, where she is currently placed in U.S. Senator Tim Kaine's office and developing health policy with an aging lens to it. So Laura brings a breadth of knowledge and really is a pioneer in the movement towards personal care, person-centered systems of care in California. So she's going to give us a broad overview of this concept of age-inclusive health systems. But after Laura speaks, we're really pleased to then turn it to a wonderful panel of experts who will respond to and reflect on Laura's remarks. And we're excited too that Janet Frank will be rejoining us for the panel conversation. So at this point, I'm going to turn it over to Laura, and after Laura goes, I will introduce our panelists. So thank you, Laura, and welcome.
Well, thank you. It's a pleasure to be here. And I'm going to start screen sharing here because sharing is caring. And we'll get going. Nice to be with everybody today and talk about this topic. I do want to mention that I've thrown in a lot of my own opinions here, so I don't mean to be representing any other organizations such as the California Department of Aging, but I really appreciate the opportunity to talk to all of you about this. So I'm going to probably talk for about 15 minutes, and then we'll turn it over to the panel for an interesting discussion. You have to remember that it's May the 4th, so we'll just do that. All right, no disclosures, and here's the game plan. I'm going to do a quick overview of aging. Part of being a physician is you are absolutely required whenever you give a lecture to present some data. So I'll just have just a few graphs to start us off. Even though I know all of you already know about the demographics, I promise to keep that brief. We'll talk a little bit about the why of having an age-inclusive system, the what, when, where, and how, and then potential impact, all in 15 minutes. So fasten your seatbelts, and we're going to get going here. So the first slide I like to show is a bar graph about likelihood of aging. Yeah, that's that. Now I know that some people do prefer to have a pie chart, so I also have that available for you, and that's the end of my data. All right, now let's move on to age inclusive, and what the heck does it mean? Well, it really builds on the principles of person-centered care. The SCAN Foundation really was the national leader in this whole area of person-centered care. And the work that they did in this area has led to, it's really become a basis for a lot of other programs and important initiatives. So let's just talk about what person-centered care means for a minute. Now I know you're all reading the slide because I have all the words on it, so we'll get that out of the way. But what I really want to do is tell you about a patient that I saw a couple of months ago. It was our first visit, and it was on a house call. She's a lady who's in her late 80s. And oh gosh, about probably 6 months before I met her, she had been diagnosed with metastatic ovarian cancer and was really trying to figure out what to do. But meanwhile, she had a host of other serious medical problems that ended up severely impacting her gastrointestinal system, her cardiac, her heart system, her kidney system. She was having trouble with some skin issues as well. She was having functional difficulties with her gait. So all of these things had been going on for years, and now, wham, she ends up with metastatic ovarian cancer. And she and her family were trying to figure out a few things, like what kind of treatment. They're offering this particular procedure. They're offering chemotherapy. I'm just going along with what they're telling me to do and doing it. And when I went over to do the house call the first time we were meeting, I really tried to apply the person-centered care. And what does that mean? Well, that we're eliciting somebody's values and preferences, and that we use those values and preferences to guide all aspects of their healthcare and use it to support their health and life goals. Well, all this sounds good, but how do you put it into practice? Well, in her case, we were asking the wrong questions. Do you want this chemotherapy? Do you want this procedure? And really the questions needed to be framed a little differently. What's important to you? What brings your life meaning and pleasure and contentment? What are your most important goals? And once we have that sort of framed out, now we can talk about these various options to now consider, do they help you meet those goals? Do they help you meet your desires? And we really ended up in a very different kind of conversation than she had had before, that helped her decide, you know what, I do want to have this chemotherapy done. I don't want to have that procedure, but this chemotherapy, I think, is going to give me a reasonable chance to meet some of my goals. And it sort of helped clarify things. I think we all had a little bit of an aha moment when we had that conversation. So that's one thing about Age Inclusive. It builds on principles of person-centered care. The other thing is it utilizes concepts from age-friendly health systems. And many of you may be familiar with this wonderful initiative. It's certainly something that we're doing over at KEC in our health system. And the idea behind the age-friendly health system are these 4 M's. This is the framework they talk about. So the 4 M's are what matters, mentation, people like me call that cognition, but it's not an M, so hey. Mobility issues and medications, which, you know, huge issue with older adults. I'm pretty sure in my career as a geriatrician, I've stopped more medicines than I've ever started. I believe in medications, I prescribe them, but we do a lot of deprescribing as well. And because I always like to tie principles back to people, it's fun to tie it back to this woman, Jean Calment. The photo that you see on the left was taken when she was approximately 20 years old.
I was just going to say, I'm not sure you're on the right slide. Sorry to interrupt. There we go.
Okay. You don't see the 4M slide right now?
No, we're not.
Then my slides
Actually,
aren't
Laura,
advancing.
your slides are not being shared.
Well, that's a problem.
Yeah.
Let's try this again.
Let's see where we're at. I think you're.
There we
on
go.
this
Now we
slide.
see 4 M's.
You do, huh?
Yes.
That's interesting. Okay. Do you still?
Yes.
Right. So I'm running your slides, Laura. So if you could just tell me when to change slides.
Okay. Have you seen any of my slides so far?
No.
Oh, okay. Well, I'll tell you what I'd like to do is go back to the beginning, and I promise to do them quickly.
That's totally fine. Take your time. Absolutely.
All right. All right. Thanks, everybody. So here's our quick overview we're going to do. And let's go to the next slide. And next slide. This is the graph I wanted to show you. Likelihood of aging, 100%. Mazel tov. And I do know that some people prefer pie charts to bar graphs. So if we go to the next slide, there it is for those who prefer that kind of a graph. We'll go to the next slide now. And what we're doing is talking about age-inclusive care, building on the principles of person-centered care. I won't go over the story again, but you heard me talk about the patient to whom I was referencing, who has the metastatic ovarian cancer. If we can go to the next slide, we'll see that I was trying to apply the principles of person-centered care. What are this individual's values and preferences? How do they guide all aspects of her care? And how were they going to support her health and life goals? And once we did that, it helped clarify some of her decision-making. Next slide, please. So the other thing that age inclusive, or one of the other things that I think it includes, is these concepts from the age-friendly health systems. Next slide, which has to do with the 4 M's that probably many of you have heard about. What matters, what medications people are on, oftentimes deprescribing medications, mentation or cognition, and mobility. The picture on the left is Jean Calment when she was about 20, and on the right is about when she was about 120, just because I like to anchor all of the theory that we talk about back into people. Let's go to the next slide, please. Another important principle of age inclusivity is using a biopsychosocial spiritual model. And I know that's a mouthful to say, but I'm a family physician, so I can't help it. I went into geriatrics through family medicine because I really believe in the principles behind family medicine. And one thing we really had drilled into us was a biopsychosocial model. And later we've added this concept of spirituality to it as well. And it's both a philosophy of clinical care, but it's also a practical guide for clinical care. And I think that's very important. If we go to the next slide, we'll kind of get a little graphic of this idea that we have different aspects of our being, right? There's the physical aspects and social and emotional and spiritual. Next slide. And where we really are is right in the middle of, whoop, there you go, stay there. We're right in the middle where all of those things intersect. And I would actually tell you, my observation and belief and actual experience as I age is that the overlap of these things become much greater as we age. So that as we age, our physical, social, emotional, and spiritual aspects of our lives actually intersect and interact even more, and more importantly, as we get older. And I think that's very important as we talk about inclusivity in the healthcare system. And finally, next slide, I think it's really important to talk about age inclusivity because I'm very informed and inspired by universal design. And I'm sure a lot of you are familiar with the universal design principles. Next slide. And it's this idea that if you design an environment that works for everybody, regardless of age, size, ability, disability, et cetera, if you design something that serves the people who may have the greatest difficulty because of how we design the environment, it makes it better for everybody, right? Think about curb cuts, great for people in wheelchairs, also turned out to be not so bad if you're pushing a baby stroller, right? Think about automatic doors, great if you're using a walker, also turned out to be pretty handy dandy if you had a bunch of packages in your arms. So these things that we started doing through universal design that were supposed to be particularly helpful so that people with disabilities could have full integration and access to our society turned out to be great for everybody. Next slide. And I would argue that the same is true for age inclusivity. Oh, let's go back, please. Thank you. And what you'll see at the bottom of that slide is sort of my thoughts about what age inclusive, and I put age in parentheses because we're talking about inclusivity, really not just about older adults, but across the health span. And I think an age inclusive healthcare system is one that can be accessed, understood, and used by all people, regardless of age, functional status, behavioral issues, beliefs, cognition, something that works for everybody. And then, of course, if it's something that works for everybody, it's also good for their loved ones as well, who are often very involved in their healthcare. Well, this all sounds really good and maybe even kind of obvious to all of you, even though we don't talk about it very much. And then this great report comes out because, maybe we're already doing this. Maybe this is all fine and dandy. Well, turns out that that is not the case. If we go to the next slide, what we'll see when they analyze data from 2014 to 2018, that 1/3 of older adults said that their care preferences were never or only sometimes considered. And if you're talking to people who are Hispanic or in the Black community, more than twice as likely to say their preferences were never considered. Next slide. There were other predictors of lower levels of person-centered care as well. People at lower income levels, people who were dual eligible in Medicare and Medicaid in California, Medi-Cal, people who had poor self-reported health status. And the other thing that was important is that people whose preferences were not taken into account were at higher risk for costly healthcare utilization. And one thing that we really know is the more we listen to our older patients in terms of what their goals and values are, back to that person-centered care, if you can remember that far back, is that oftentimes the care they want is not the most expensive care. Sometimes it is, but often it isn't. So it turns out that when we really take people's preferences into account, most health systems actually save money. And so this is sort of a bad news, good opportunity kind of slide in my view, because even though it's bad news that we're not doing a good enough job, the good news is this is all stuff we can do something about. This is really something, and my colleagues on the panel will talk more about this later. We can make changes in these areas, and it turns out that it makes business sense as well. So next slide, let's talk about what some of the challenges are. And this is where I would like all of you to start thinking about yourselves, either in terms of if you're a direct care provider like I am, and or if you're involved in a healthcare system. How can some of these principles we talked about related to age inclusivity be incorporated into your practice, whether it's your individual practice, your agency's practice, your health system's practice? And what are the benefits that bringing that kind of care might accrue to both those you serve as well as to your own organization? I know what you're already thinking, so don't start with me. I don't have time. This takes too much time to do. The client doesn't want to do this. I don't want to do this. I don't know how to do this. It takes too much time. We don't get reimbursed. It takes too much time. Yeah, I get all that. But it turns out that the investment we make in the time to have these conversations up front really helps us down the line. I guarantee you that that conversation I had with the lady I told you about, where we talked about her goals of care, are now going to make it easier every time we have a conversation about a new either opportunity or decision point related to her medical care. We're going to be able to refer back to that original conversation, and it'll go much more smoothly and easily, and frankly, much more efficiently as well. So next slide. I'm just going to take you, give you a minute to see this slide for those who can see it, and I think it's getting described for people who can't see it. And the reason I like this slide is because we're kind of blaming the cats, right? Any of you who know me on this call know that I like cats, so I'm always going to use a cat example. But this is, I think, what we're often doing in the healthcare system. We keep blaming the older adult. They're too difficult. They're too challenging. You know, they, instead of looking at the structure of our systems. It's really the infrastructure that should be providing the support, the systems that should be providing the support that are problematic. Now, I'll tell you, this is good news because, again, we can do something about these sorts of things. We could do something about the structural elements, the policy elements, the system elements that need to be there to provide appropriate support. But in order to do that, the first thing all of us have to do, and this is a personal challenge to everybody who is on this webinar, is to first look within. Next slide. Because it really turns out that sometimes we don't see ourselves for what we are. Sometimes, and I'm sure that I'm the leader of the band on this, we have sort of self-inflated ideas of what we're doing or how we're behaving or whatever it is we might be running. So I think it's really important to take an honest, good look within to understand what each of us can do about things. I think that we really have to think about our language. Instead of saying somebody's a difficult patient, we talk about maybe a challenging situation. We're not just a bystander, but we're an upstander. We're an ally for others. We're educating ourselves. We're learning about other cultures. We're educating colleagues. Next slide. We're really looking at how we can, what each one of us can really do in order to move the concept of age inclusivity forward. How could your system be more age inclusive? How could you use this as a framework for what you do? And I think it will be so important as we look at issues like measurement and program design and policy to think about how you can also inform our state, our current master plan on aging, the next iteration of the master plan on aging, and how we can do a better job utilizing these principles. And I have to say right now in particular, I think it's important to remember that we all need to vote and encourage the clients and patients that we serve to vote as well in order to keep person-centered principles at the fore. Next slide. So what's the impact all of this can have? Well, I think we actually can change the way healthcare providers think about how we practice medicine, how we deliver healthcare. I think we need to create higher expectations and deliver on them. I want my patients, the clients that we serve, to have high expectations and to hold me and my systems accountable for delivering on them. I think we can really improve the lives. We talk about people with chronic health conditions, right, or functional impairment, those who love them. Next slide. But really what we're talking about is if we do this for people who may be the most vulnerable or the most susceptible to problems in our system, we end up helping everybody, just like universal design ended up helping everybody. Next slide. So this idea that if we don't change and something magical just happens, I'm sorry to be the skunk at the picnic, but that's not going to work. That's why I think we want the public, we want people who have expertise and experience in care for older adults and for people with disabilities to really weigh in and influence the system so that we're not waiting for something magic, but really working hard to create the system that all of us want for ourselves and our loved ones. Next slide, because we have to remember that all of us are aging. So we do need to be doing this together as a group. I really appreciate the time to talk to you a little bit about this. Sorry about the glitch at the beginning, but hopefully it worked out for folks. And I'll turn it back over to my colleagues now.
Great. Well, Laura, that was such a wonderful introduction and context setting for our conversation. I think so many important themes that you raised about how we consider both the policy and the system elements of developing an age-inclusive health system here in California. And I love that you've pretty much, developed this whole new concept around age-inclusive health system, focusing on building on concepts of person-centered care, utilizing concepts of age-inclusive, of the age-friendly health systems, but also looking at the biosocial psycho model, and finally, being informed and inspired by universal design. And somebody, Bill Pelter, had a really interesting comment in the chat while you were speaking. I think it was in our last webinar, we were talking about something with person-centered care, and a commenter made the remark that the term person-centered care has a great intent, but that it's also important to consider, the person's relationships and their communities around them, so that it's not just about them as a person, it's about how we support their community, whatever that might look like, because that community to them is critical to how they age and how they live in the community. So with that, I'm super excited now to introduce all of our wonderful panelists. We're going to bring back Janet Frank from the California Commission on Aging and UCLA Center for Health Policy Research. We have with us Zia Aga, who is Dr. Zia Aga, the Chief Medical Officer and Executive Vice President of West Health Institute. Laura will continue remaining with us for the panel discussion. We also have Gretchen Alkema, who is Vice President of Policy and Communications with the SCAN Foundation, and really a pioneer in helping, bring forward this concept of person-centered care for older adults in our health delivery system. And then finally, last but definitely not least, we're so honored that Jenny Chin Hansen is here, who is the former CEO of the American Geriatric Society, but also an independent consultant with her philanthropy partners. And Jenny, as you all probably know, was really the pioneer of the movement to develop more integrated service delivery through the program for all inclusive care for the elderly. So welcome to everyone. And again, we want to ask our audience to utilize the chat and utilize the Q&A function. We're going to have time for you to actually ask questions speak if you would like to. So we are turning to you for your engagement as well. So at this time, what I'd like to do is I'm going to turn it over we're going to start with an opening question for each of our panelists. So I'm going to start with Dr. Zia Aga. And Zia, we heard in Dr. Mosqueda's presentation that we need to design systems that are responsive to the unique needs of older adults, as well as people with functional impairments of all ages. And emergency rooms are an example of a healthcare setting that's not always responsive to the needs of functionally or cognitively impaired individuals, regardless of their age. And West Health has been a real leader in developing this concept of a geriatric emergency department. Can you tell us a bit about this work and how it's being advanced across the state and the nation?
Thank you, Sarah. Thank you so much for the invitation, for hosting these very informative webinars. And Laura, thank you for such a wonderful presentation that really sets the stage. If I take some of the threads that you talked about, the 4Ms, the user-centered and person-centered design concepts, one manifestation of those sort of frameworks and those ideals is our work in the geriatric emergency departments. And if you think about the 4 sort of pillars of that work, really it starts with, how can we create an emergency room that can provide whole person care, that can allow seniors to have their wishes be met, perhaps at one of the worst times when somebody is in ER. How can we address them? And we do that by, one, having a more interdisciplinary and holistic approach, which includes screenings that go well beyond what are offered normally. And we will learn about that in a small video that we will share with you. We focus on bringing all the disciplines, because geriatrics truly is a team game. So it's not just the ER doctor and the ER nurse, but other disciplines that are brought in. And we really focus on care transitions. How do we allow these patients to not just go to the hospital or nursing home, but to go home or to wherever they choose to go and get the level of care that they want? And we do this primarily through training and workforce development of the existing staff, so sort of the ladders model. And we do it through protocols and accreditation programs. And later on, I'll talk a little bit about what we're doing with California and nationally. But I think it's time to share a quick video that will highlight some of the work that our partners, UC San Diego Health, my dear colleague Rachel Tolia is leading. And that'll sort of help set the stage for some comments after that about how we are taking that learning and spreading it in California. So Sarah, can your team put up the video for me?
Yes, that would be great. So Nancy and Maria, if you could pull up the video now, that would be great. And we'll go back. There we go.
There we go.
Every day, 10,000 baby boomers are turning age 65. And we know that this population, just like the pediatric population has special needs, our seniors have special medical, social, and other needs that we can really address in a unit like this. Earlier this year, we opened the Gary and Mary West Senior Emergency Care Unit for patients over the age of 65 who have a positive ISAR score, which is the identification of seniors at risk. Those patients will be placed into our specialized area here. We can see that this area is different than our current emergency department space. This area is specially designed for our seniors so that it's a comfortable environment for them to actually get their prolonged stay in the emergency department and get their care during that time period. There are several architectural elements that will make it senior friendly. So for example, there are non-slip floors, there is lighting that's circadian friendly so that patients will have decreased interruptions with light and sound. Much of the rooms and the area is designed to be very quiet so that sound does not interrupt patients while they're resting and recuperating here. There's also artwork by Aaron Cheng throughout the space that helps orient people to the fact that they're in La Jolla, in San Diego, and helps decrease agitation and uncertainty. There's also technological enhancements within each room, which keeps patients and their families up to date on the care that they're receiving and the expected treatment plan. We have a nursing team that's very well versed and trained in advanced geriatric care. Specifically, we have a group of Genie nurses, or Geriatric Emergency Nurse Initiative experts, that are focused on advanced geriatric care screenings and have the clinical decision support tools to actually bring other resources to the patient in the emergency department.
So the first exam we do in triage is called the ISAR. ISAR stands for Identification of Seniors at Risk. This has 6 questions that are a good indicator of whether the patient, the senior, is going to have a poor outcome if we discharge them from the ER today. Such questions as, do they take more than 3 different medications a day? Have they been hospitalized for 1 or more nights during the past 6 months, excluding a stay in the emergency department, but an actual stay in the hospital? Or in general, do they have any serious problems with their memory? It also talks about care prior to coming to the emergency department, and if they are, do they need care prior to coming to the emergency department, and do they think they'll need more care now that they're in the emergency department? So it's a very good indicator of a risk if they are discharged from the emergency department.
Our goal in the senior emergency care unit is to improve transitions of care and to hopefully decrease hospital admissions so that we can give patients what they desire, and that's usually to get home and to get to a more comfortable environment. The research that we're doing is looking at all of these screening tools, looking at innovative models of care, and not only improve the care for our community here in San Diego, but also demonstrate how excellent senior care can be achieved in the emergency department to health systems throughout San Diego, California, nationally, and even internationally, where we can really be the beacon for excellent emergency care for seniors.
Thank you. So you heard from Rachel how this work is now inspiring us to do the spread and scale strategy for geriatric emergency departments beyond San Diego. In San Diego, we work with our county leaders to create 18 GEDs, making San Diego County the first county in the US to have all of its ERs have geriatric certification. And working with the state and our partners at UCSB, we're developing what we call the Senior Emergency Care Network in California. That network today has 48 geriatric EDs, and our goal is to be close to 100, which will allow us to provide that level of care to all communities across California. And we're not going to stop there, obviously. There's work happening at the national level. There are more than 300 certified GEDs right now and growing. Large healthcare systems are participating in this work. The Department of Veterans Affairs, which I used to belong to, I'm really proud of, has made this a big priority. The VA sees 40% of its ED population is senior and special needs, and they're going to have 100 GEDs over the next 2 years. So really, this is now going from an initiative to becoming a movement, and it's a manifestation of the framework that Laura talked about. What does age-friendly look like, and how do you manifest it in a healthcare system?
Fantastic. Well, that was a wonderful overview, and I really appreciate the video as well, Zia. And I'd love to now turn to my colleague, Gretchen Alkema. Gretchen, you heard Dr. Mosqueda note that a key feature of age-friendly health systems is aligning care with individual goals and preferences. The SCAN Foundation has led a great deal of work that focuses on developing processes to document an individual's preferences while also advancing person-driven outcome measures. So can you talk to us a bit about what this process of person-driven outcome measures entails and what's needed at the policy and the system level for us to advance this work?
My pleasure, Sarah. Great to see you. Thank you to you and the CDA team for your leadership, for this really important conversation together, I think at a critical time as we're looking at a lot of transitions in care processes that are at the state, that are inside the state, but also in health systems across the state in terms of what value-based care looks like. And when we think about value-based care, it depends on what seat somebody is sitting in, as depending on what value means to them. And when I think about consumers and what value historically has meant to consumers in healthcare, it means being able to live their absolute best life at the highest functional level with the least amount of intervention on the day-to-day. I don't know anybody who woke up this morning and said, God, I can't wait to go to the hospital or the nursing home. And so how do we create health systems that and health engagements that's person-centered, that helps all of us live at our best level, and being able to live out in the world. A second concept of that vision is that people's needs are both considered very actively and then met in a timely, organized, convenient manner by competent providers. And that part of that competency is that they know who I am and what I need, what my needs, values, and preferences are in a meaningful way. And then additionally to that is that that consumers have the confidence of navigating care systems by themselves or with the support of family members or external parties to be able to get the kind of care that they need. And so in thinking about the totality of that, I just so appreciate all the remarks that came from Dr. Laura Mosqueda to start us off. And I would be remiss to say that, you know, she's so humble in all the work that she did. But truthfully, back in about late 2014 moving into 2015, we reached out at the Scan Foundation to both Jenny, who was at that time at the American Geriatric Society, and Laura Mosqueda and Kate Wilbur at USC to help craft what is this thing called person-centered care. You know, lots of people are talking about it. Lots of people are putting some, you know, framing around it, but there wasn't really one way of describing person-centered care. And you know, Laura and Kate's work charging that forward with this amazing group of experts was then published in the American Geriatric Society. And there's a kind of a whole description about what's that definition that she had in her slides, but then how does that get operationalized through systems, both at the workforce level, at the kind of planning and processes level, and what are the elements that really matter to people as they go forward in that nice kind of circular diagram that Laura shared about, you know, how am I physically engaging? What is my mental capacity and engagement? What are, you know, what is my emotional availability? And then making sure that people feel connected and honored in their spiritual side, and that all those pieces come together to make life, you know, be active and meaningful for individuals. So in a minute, I'll drop the link to where you can find all those resources in that article in the Journal of the American Geriatric Society that still serves as the national base plate for what person-centered care is, how it's defined, and kind of the macro vision of how you put that into play. One of the critical pieces that we know inside of health systems is that, you know, if you don't measure it, it doesn't matter. And it doesn't matter from payment, it doesn't matter, you know, that all of us are driven by some form of how well am I doing, and that includes health systems and providers. And so we've been working with the National Committee for Quality Assurance for some time now on the development of person-reported outcome measures that drive care planning, and ultimately we hope will drive payment to high-quality providers who are putting the person at the center, particularly when it comes to somebody with complex care needs. As I think many of us know on this call, and Laura so eloquently described, that if I have an acute care need, I break my arm, I have a massive heart attack, it's about addressing that very particular thing. But when we're talking about older people, people with disabilities, people with complex care conditions, where it's never really just one thing, it's a multiplicity of experiences and factors and functional levels that are complicated, and it's not just addressing one piece, and you know, you squeeze the balloon on one side and it starts to blow on the other side. From that metaphor, it's about saying, what matters to me? What's at the core of my experience today? What do I care about doing 6 months from now, that if we don't get a handle on X, Y, and Z symptoms or functional level for me, I'm not going to be able to do that. And so that's taking a really different approach to care. And so part and parcel of that is saying what matters to an individual from a person-reported outcome measure about the way in which they live their life, not did I get my hemoglobin A1C to go down a couple of points, which, hey, that matters for sure, but it matters only in terms of how I get to live my life every day. And so, you know, working with the team at NCQA as they're developing and really pushing out a whole series of person-reported outcome measures, we're seeing state Medicaid programs excited about this and wanting to see how they put it in their contracts moving forward. we see it as an opportunity for Medicare Advantage plans to really become differentiators in the marketplace by saying, we're putting the person and their needs and preferences at the center point of the care delivery experience, and all the clinical measures are relevant only to which that person's needs, values, and preferences are driving the care experience. And our hope is over the long haul that the Center for Medicare and Medicaid Services, as well as state players, will feel real connectivity to what these measures are about, and will want to drive payment to those actors who are putting it really at the center point of the care experience. So I look forward to continuing the conversation. But I think the long and the short of it is value depends on the person who's at the center point, and we believe that the center point should be that older person in context of their family caregivers and their loved ones in the context of their community. I really love the comment that was in the chat bar earlier about that. I'm a social worker from way back, and person and environment is the core of that. And so we have to think about people inside of their context, but it has to start with what matters to me first as the older adult. Thanks.
Fantastic, Gretch. I think that is such a wonderful kind of tie into everything that Dr. Mosqueda was speaking about, and highlighting the amazing work that you all are doing to advance the measurement of this, and really looking at person-driven outcome measures. And I think it is really exciting to hear about states talking about this, and states thinking, how can we start, in addition to our clinical measures, how can we start measuring based on what matters to the person? And then that drives policy and funding. So at this moment, I'd like to turn it now to Janet Frank, who really, Janet, you've done a lot of work both with the UCLA Center for Health Policy Research, and now as a member of the Commission on Aging. You've done a lot of research and advocacy on the issue of older adult access to mental health care and the intersection of healthcare and behavioral health. So as we talk about age-inclusive health systems, what do you think is the most critical as we consider opportunities for building these models of care? And how should we consider behavioral health as part of that continuum? Oh, muted.
There we go. Thank you. Well, behavioral health integration into healthcare is really a huge issue. And I think that as we're considering all the very important things that have been discussed up to now, when it comes to behavioral health issues, which are defined as the combination of both mental health and substance abuse rolled all together into that one term. So it's a little bit more, a bigger term than just mental health. We have to get the people there. Our research at the Center for Health Policy Research showed that older adults are very much underserved as it comes to meeting their behavioral health needs, and state data supports that. In fact, I believe that in 2018, that the state data showed that if you take a conservative estimate of the prevalence of mental health issues with older adults, say anchor it at a 10% range, the number of people served in the state of California equaled about 4%. So that means 96% of people, older adults, older Californians with mental health, behavioral health issues, were not getting their services, were not getting their needs met through services. So it really is a huge issue. In addition to this major issue about trying to address the penetration issue of services, there is also great geographic variation across the state. Counties, it goes county by county, and counties that have an older adult system of care within their behavioral health units just do a much better job in meeting needs for older adults than those that do not. So I think we really need to take a systems approach to try to address these things. The other thing that our research showed was that because of the lack of leadership at the state and a lack of older adult system of care at the state, that there was this issue of the counties each deciding what is the best way for them to operate. So we felt that leadership at the state was a really important issue. CDA does a great job in leading efforts around older adults advocacy and addressing consumer issues. But behavioral health money is in the Department of Healthcare Services. And right now there's not one person in the behavioral health unit in the Department of Healthcare Services that has this kind of expertise. And so one of the things that the Commission has done this year is we have crafted a budget ask in both the Senate and the Assembly. Senator Wiener is leading it in the Senate. Senator Nazarian is leading it in the Assembly. And we're trying to get funding to have a geriatric leadership specialist within the behavioral health unit. We think that while this is a tiny step, it's a very necessary step to be able to have a voice at the table. As CalAIM is being implemented, the Center for Medicare Innovation is being implemented, all of the various opportunities to really address the needs of older adults and their behavioral health issues. We want to make sure that we have somebody there with that kind of expertise who can really push this forward. So that has been a big effort of the Commission in the last few months. And I think that, there's lots to do, but at least that is a step in the right direction. So.
Thank you, Janet. Such an important point. And I think that, particularly with COVID, we saw the tremendous impact that it had on older adults in terms of mental health and isolation and loneliness and depression. And, importantly, we've heard a lot of focus on the impact that COVID had on our youth and young adults. Very true. Yes. But I think what often gets lost is exactly what you're saying, is that older adults really have a crisis in terms of being able to access culturally competent behavioral health services, which is certainly a key element of ensuring that we have an age-inclusive health system. So thank you for the Commission's advocacy on this issue. I think there's a lot of opportunity to raise awareness on the research you've done that actually documents the unmet need in this area. And certainly it's something for us to consider too in the next iteration of the master plan. So thank you for that. So now I'm super happy to be able to turn it to Jenny Chin Hansen. Jenny, as the pioneer of the program for all-inclusive care for the elderly, you are very familiar with how to develop models of care that are responsive to what older adults want and need. And more recently, you've been involved with a project that seeks to develop dementia capacity in geriatric emergency departments. Can you tell us more about this model and how it's being advanced, and any other thoughts you have too, just about this general concept of age-inclusive health systems, particularly as we think about things like cultural competency and language access? So thank you for being here, Jenny.
Well, I'm delighted to be here, Sarah, with these colleagues who are all participating here, and I'm going to be building on Laura's comments and what Dr. Zia Aga has said about the geriatric emergency departments, and again, my long-time affiliation with the SCAN Foundation. So all this is rather incestuous. But first of all, I'd like to really take up on Laura's comment about this larger framing and the choice of the word inclusive, which does stretch this much further. It's interesting that here in San Francisco, the project you have asked me to speak about, that's funded by the Dolby Family Foundation. And that's the philanthropy that has helped San Francisco move a bulk of our work in Zia's tremendous leadership with West Health on getting hospitals accredited as geriatric EDs. And it's quite interesting, as a side note again, that UCSF, UC San Francisco, has chosen the frame, even though they have a geriatric ED accreditation, they call their ED age-friendly ED. So the shortcut is AFED. And so the sense of the terminology of how language is also so important. that the ability to think about people living with disabilities coming through these portals and having some of the concepts that Zia has brought up about what constitutes the performance and the expectation of an accredited ED for geriatrics right now, but it is even much broader. And so I come back to the piece on dementia, which is a particular handle that we are focusing on here in San Francisco. Thanks again to the Dolbys. Mr. Dolby, as is publicly known, and this is the Dolby family, the sound system, ended up having the condition of Alzheimer's, and in the course of that went through some experiences. And here's this family that has resources and has knowledge about it. Even he had a challenging time going through the emergency department. So thus this focus of having the core work of being geriatrically more competent, but then the work of understanding cognition issues writ large, whether it's with some of the other special dementias or Alzheimer's. And now this ties back to our master plan for aging work, because within this, we started off with a task force on Alzheimer's disease and the master plan. We've merged this together. So I think that the ED work that's happening here in these 3 hospitals in San Francisco, besides UCSF, there's Kaiser San Francisco and our safety net hospital, Zuckerberg General Hospital, each of which with core different populations, but we're all thinking about how does one focus on the screening of people who come through who have cognitive issues, if not dementia. And sometimes people have a diagnosis and other people are presenting without a diagnosis. And so that's part of the work that we're trying to do, because our clinicians are finding that many of the people have very vague descriptions going on when they come through. And some decade earlier, some of our emergency physicians had noticed that maybe almost 60% of the people, and this was not a formal research study, but their collection of their anecdotal and measurements at that time, where people were coming in through with cognitive issues, and they didn't really need to use the emergency department. And so that really got people working. And then we've built down the work now that UCSD has done, and especially West Health. So we are working so that there's screening in particular in terms of best tools for determining people who need some further assessment, if not a referral to a memory center, to a neurologist. So it's not easy work, because one thing you might probably know, and we knew this going in, but certainly if early experience tells us, even when people are identified as having perhaps some needs to have further assessment with their memory, people don't necessarily want to go to the referral source that you refer them to. There's huge stigma, as we all know, about Alzheimer's and dementia. And that's a barrier in and of itself that we have to do. It's interesting, we used to talk about cancer. People wouldn't talk about cancer in the past. Can we get to the point in our lives where the ability to see that a dementia or Alzheimer's doesn't have to be as stigmatizing, and the fact that there's work, there's interventions and ability to do that. So our emergency departments here now are thinking about both geriatric content that is important that Zia mentioned, but then also perhaps some deeper work. And we're working nationally with a research team from Yale and from the University of Wisconsin and Northwestern and from St. Louis to really think about what is going to help that ability to diagnose, to have best practices, have better communication in the ED, and how to refer people as they transition. So these are some things that we're doing, and I think it's highly needed, because I think every emergency department is facing this. One of the things we were able to facilitate is a video that's under production now for all EDs, and it's being funded by AERP nationally, as well as work through the collaborative of geriatric emergency departments that ZIA and the West Health are funding, so that we can use this as helpful tools for others. And I'll have to close with one other comment. There are this whole need for behavioral health knowledge that Janet has brought up as a commissioner, but all these content areas about aging, gerontology, and geriatrics. There are so few people who are specialized. I mean, Laura is one of our unicorns that we happen to have here, to have somebody so knowledgeable. But I wanted to give you an idea for our public. I just today confirmed with the American Geriatric Society, there are just over 5,800 certified or boarded geriatricians in the country. Do you know how many pediatricians there are that are boarded? 60,000. So here we are with the growing population that we have. We have under 6,000 geriatricians. We have more than 60,000 pediatricians. We don't have the kind of expertise and knowledge. And so our ability to diffuse knowledge, like in the geriatric emergency departments, Zia and I are working together as part of this to use the UCGEDs to be part of our leverage of change, of getting knowledge to other disciplines, other specialties, and using that. And also in our state, we have 4 geriatric workforce enhancement programs that work with academic medical centers and family members and community agencies. I know San Diego is represented here. We have somebody from the School of Social Work at San Diego. So the ability to train up, to educate people on aging, changes in aging and clinical conditions will be better for it. And we've got to do it by doing both, producing more social workers and nurses in our workforce. But the reality is it has to come from the ground up. And this is something that I'm strongly in favor of and want to bring together some of these programs and do a crosswalk so that we can leverage and effectively force multiply people who have knowledge and capability in aging and geriatrics.
Fantastic. I love all the different themes that are coming up, Jenny. When you talk about, this movement towards kind of specializing and having the capacity, it's really a dementia capable geriatric emergency department. But I think what we would love to see too is how can we make all of our service delivery age inclusive and dementia capable? And this is something we're also talking about at the level of, just our information systems, and how can we ensure that wherever people enter the system, they get this kind of no wrong door approach, but that system also has the capacity to respond to and help individuals and their families who have cognitive conditions. So it's like, again, this concept of universal design, of meeting the needs of everyone, but also having the capacities to specialize. A few other things that come to mind. One is this issue of the stigma of both having, some form of dementia and also behavioral health or mental health needs. And part of the stigma, I think, has contributed to our physicians not wanting to always document if a person has Alzheimer's or related dementia, but how critical it is to assess for it. So what's really exciting is that the state, you all may recall, there was an investment in last year's budget, $25 million focused on called Alzheimer's Aware. And that was to develop an assessment for Medi-Cal physicians to kind of do a baseline assessment of cognitive capacity for Medi-Cal recipients. And it's a really exciting and important development. And I believe that the work has been led out of UCSF and that they have submitted their model kind of assessment tool protocol. So I think there's lots for us to learn about that. And how can that sort of protocol then be replicated in the private sector as well, or in the private healthcare delivery system outside of Medicaid. So it's a lot of really important things to consider. We also have had some wonderful comments in the chat. I want to turn to Laura just to get some kind of comments that she has after hearing from our panelists. But I do want to highlight some of what we have seen from a really good question that just emerged was, can you elaborate a little on cultural competency, that approach, and how system development can support it as a critical part of engagement and improvement of services. And so I want to turn to you, Laura, to see if you have thoughts on that. And then we have a couple of other questions from the audience that I want to turn to. And just, Laura, if you could also just think through, what sticks out to you right now in terms of important policy opportunities as we consider the next iteration of the master plan.
Maybe I'll start with that, and then we'll come back to the cultural competency question, because I think that is absolutely key, but I just think it'll flow a little bit better if we do it this way. And you can figuratively bonk me over the head if I forget to get
that's great.
back to that. Okay, so notice I said figuratively. All right, so I think the whole issue of measurement is very interesting to me. So like my sciencey research hat loves measurement, and I understand that money and measurement drive behavior. I also think we've gone a little bonkers with measurement. And what happens is when we start measuring, and I think it's really important when you look at the work, for example, that Mark Cohen and his group did. That was the report I showed you earlier. It was really important that they went and looked at numbers and were able to measure what was happening so that we know where the problems are. But I'll tell you, as a clinician, everybody wants to measure everything. And if we're going to add more measurements, we got to take some away. And we need to make sure that what we're measuring is meaningful and not just, it's too easy to check a box and say, I've done it. And I've been through this. I've got a 90-year-old father. I've got a 90-year-old mother-in-law, and I help them with their healthcare systems. And I see all the time the check the box syndrome. And I'm sure we're guilty of it as well, where I am. But so I think we have to be really thoughtful. And I would love to see a conversation about different approaches to measurement to make sure we're really capturing what we want to. And it isn't just because we want to capture it, but it's sort of like teaching to the test, right? If you're going to get quizzed on it, we're going to teach you about it because you're going to get it on the test. And the same thing happens with measurement. If you're going to, it signals, hey, this is important. And then of course, the funding also signals that it's important as well. And I think when we look at what needs to happen at both state and federal levels, how are we going to work in concert and make sure that we're not at odds with each other in terms of meeting the needs, that we have funding streams that are aligned, that are motivating the kind of behavior that we really want to see to provide the care that we want to provide. So for example, it's great now that in theory, not just in theory, in reality, we can get paid if you're a primary care physician for chronic care management and all the time that we spend outside of the office. But the reality of what you have to document and what has to be measured in order to get that means that a lot of us just don't bother because it's not worth it. So when we're looking at policies or new systems, we have to put something in place with the end user in mind and make sure that it's going to not just sound good and look good, but actually be achievable. So I will now get off my soapbox on that. The other thing I'll mention is that when we talk about training, which I think is critically important, we're looking right now at all these opportunities for better wages for direct care providers, yes, and training for direct care providers. The training, should include some of the principles that we talked about here, along with really practical tools for how to do it. And I think that when you're talking about real person-centered care, when we're really talking about age inclusivity, it has to be interactive. There has to be like fun, engaging role plays and different ways to do it, which then I think also leads us to some of the cultural competency piece. And I see the cultural competency kind of at the big level and at the individual level. At the big level, it's our awareness and our understanding and like continually realizing there might be something else going on here. So sort of that are we in a system that's continually having this in our face and bringing this to our awareness? Then at the individual level, every time I'm serving a patient who comes from a different culture, it's a new opportunity for me to learn about that culture. And to go and look it up and not put the onus on them to have to tell me all this stuff, only to the extent that they want to, but for me to learn more about that. So I think that's very important. I'll say one more thing and then I'll stop if that's okay. Is that okay, Sarah?
Please, please, please.
Okay.
Yes.
And the one other thing gets to what Jenny mentioned in terms of the importance of having more people who understand geriatrics and gerontology, who understand aging. And I think we need to look at different methods of doing things now. So for example, I was extremely lucky during my fellowship in geriatric medicine. I was at a hospital called Rancho Los Amigos, where I got so much great education from nurses and social workers and PT and OT and speech and language pathologists. Critically important part of my education. And what we often see is that there are some specialties that do tend to be more attractive to women than other specialties. I would say, understanding it's a generalization, that might be true in social work and nursing. And very often when we're younger, as women, we may be more interested in kids. And as we get older and we go through our own aging process, and we have aging parents and friends with aging parents, that we now begin to have a growing interest. I would love to see career change pathways for folks in nursing and social work, for example, so that they don't have to quit their jobs and go through a whole new training, but some way to sustain their living and say, I want to focus now and get more training in geriatrics at a time in their lives when they might be more interested.
Yeah.
Thank you.
That's fantastic. Really excellent themes that are all building off another. I know that Gretch had a comment, and then Zia, I would love to hear from you after we hear from Gretch, and then turn to our audience for some thoughts as well.
Much, Sarah. I'm just so delighted that Mark Cohen from the UMass Boston team is able to be here on this webinar today. So we may be able to pick his brain a little bit, and he's in the chat for those of you who are chatting about. We're just, we were so pleased to be able to support that body of work to get a baseline on what is the state of person-centered care in America. And we're looking at how to continue understanding that trajectory line, because I think it's the most fundamental aspect of getting to measuring what matters, which says, are your care preferences being considered in the care process? And and then the additional kind of operationalization of that is, how can that come to pass? How might a health system who says, we really care about that, what do we do about that? How do they put that into practice? And I just think about simple things like, there are many preventative screenings that many of us do, where I walked into an office and I immediately got an iPad as I was walking in and waiting in that 20-minute, window in the waiting room. And, what if, and they had me answer all these questions, what if we did that for every single health related visit that, you're entering into a kiosk, you put in, what is the two most important things that matter to you today that your provider hears at this visit? And most of the time, it's probably not going to be some super technical language. It's going to be something that's real ground floor on what's happening with people. And that's a mechanism to ensure health equity, is that everybody has the opportunity to express their needs, values, and preferences at every care visit. And it's going to come about in different ways. It's going to come out as that person wants to be the voice, or a loved one, they want to be the voice, or, people are using text messaging now and other kinds of virtual connectivity arrangements to communicate with providers in advance and post-visit. How about we embed these kinds of questions into that and utilize AI processes to understand what is it that people are saying over and over and over and over again, so that care providers can put that as the center point of the care as they move forward, and share that information with other providers where is appropriate inside of health systems, so that doctors know that, Mrs. Jones is struggling with this issue. She's struggling with fear of falling. She's struggling with, how am I going to get my medications, and struggling with food access issues, all of those kinds of things that come out when you ask people that really kind of simple question of what's the most important thing you want your provider to know at this visit. And I think people are afraid to ask that question for wondering, can a health system actually respond? And our answer is health systems can respond. That doesn't mean the health system has to absolutely deliver that service, but they are the conduit and the connecting point to help people get what they need out into the world and the community and connect them with relevant community providers. So I just think there's a way that as we understand how little this conversation is happening for older adults, how much we can actually respond with really, really simple means that include virtual care technologies at the core. So I'll cede my time to Dr. Aga.
Yes, please. Thank you, Gretchen. Zia, please jump in.
Yeah, no, thank you, Gretch. I wanted to jump in on a comment that Laura made, measurements and payments. So, we think a lot about sustainable change. And to do that, you really have to align incentives. And if you think about the measurement question, there's some low-hanging fruit, clearly. And we've demonstrated that through our data dashboard work, Sarah. There is data out there that just needs to be sliced and diced by these subpopulations. So for instance, HCI and OSHPD used to collect data from ERs, but not by age. That's easy to do. That starts to shine light on how we are doing with this population. Also, the focus on being more person-centered. Some of the issues that are important to seniors are not just diseases and diagnoses, but go beyond that. And that data is available too, but not often presented and used in the right way. And then on the payment side, I think there's an opportunity to recognize that, as a physician, I can literally, with one sign or one click, order a $10,000 MRI, but I can't pay my nurse to do care transitions from the ER. I can do that from the hospital, but if I want to send somebody home and not just send them home, but actually coordinate the care, so when they go home, they can get the services, there's no mechanism to pay for that today in our system. So there are opportunities to work with the state, to work with the federal government, to sort of recognize that we need to start to resource these home and community-based services, the psychosocial aspect of care, because it's so important for this population.
Absolutely. Some really important themes that I'm hearing, around documenting what matters to the person and ensuring that the assessment includes that, really being very intentional in developing our workforce to have the training and the expertise on these issues, and developing perhaps incentives for people to enter this field, whether it be mid-career or early career. We really need to think creatively about how we address this from all aspects. And also, again, putting a lens of cultural competency and language access on everything that we do. So really important considerations as we move forward. I wanted to clarify too, I appreciate Anastasia Dodson, who is the Director of the Department of Healthcare Services Office of Medicare Innovation and Integration, is here with us, and she had an important clarification. I had mentioned the Alzheimer's Aware Assessment that is being developed for the Medi-Cal program. That's an assessment that would be for everyone, but it would be a much more effective way to screen for Alzheimer's than right now. So it's really, I think, a potential game changer in terms of how states can assess for cognitive capacity and potential of dementia. So we do have, let's see, we have a number of attendees here. We've heard from Mark Cohen, we've heard from others in the audience. I want to see if any of our participants would like to, in the audience, would like to say anything or have a question that they'd like directly to ask our panelists at this time. I'm not seeing any hands being raised. And I know we only have a few more minutes. So I want to see if at this point, as we're bringing together our work on these issues and thinking what are the next steps for next year? If you had your way, what would the specific recommendations be for the state to do at this point, whether it be related to outcome measurement, whether it's related to assessment, or developing our workforce capacity, what have you? I would love to hear from each of you. What are your specific recommendations? And Janet, why don't we start with you?
Thank you. Yes. Well, I want us to remember we have a great resource and many expert training programs in California for gerontologists. And these are the people that can really work at the community level, linking services, running programs, designing things. And so I just want to put a plug for gerontologists and make sure that we don't forget about them as we move forward in both looking at the composition of teams, looking at person-centered care programs, and also the whole issues of integrated care. And I think that the clinical side is, of course, extremely important, but let's not forget the gerontologists.
Great. Thank you so much for that. Jenny, what are your final thoughts if you had a recommendation to pass forward?
Well, I think that I'll bring up workforce again, since that's such a major factor. I started to allude to the fact that the geriatric EDs are moving and growing. Certainly, I mean, the VA system, Kaiser, others are. And then also there are some of these larger programs from a national level with the geriatric workforce. And it's geared for family members and community organizations. And there are technical things like the nurses improving healthcare for health system elders. And there are, you know, I think about 400 of them around the country, but a lot here. If we could do a crosswalk on this, to be able to take that and the age-friendly health systems in a way to begin to think about how do we build this for sustainability and tie that to some of the training that are focused on community health workers and promotores that already are in play. Is there a way to help equip people with content knowledge that just helps a wider group be informed? I mean, in the chat, there was somebody who was saying they would, as a person who is growing older, they wish they had some knowledge earlier, for example. So can we democratize our knowledge more fully, as well as thinking about it from an educational perspective, and not wait until we age before we realize how important it is. So there's just a workforce opportunity that I think we can build on and build in with things that are going on, and not creating another entity, but looking at what's leverageable right now. And then I used the word force multiply earlier, is just get it so that we can grow this base much more quickly, because we need the knowledge.
Couldn't agree more, Jenny. I love the theme of let's build on the opportunities that are out there right now. We're seeing tremendous investments in building our community health workforce. And I think that there's a lot of opportunities to think about where that aligns with our age-inclusive health systems. Similarly, we're seeing a lot of investments in a lot of areas of the workforce, and also in behavioral health. So I think, again, as Commission on Aging is highlighting, how can we ensure that that includes aging as well? Just some of those important initiatives. So we have heard, let's see, concluding remarks from Gretch. What would your recommendations be at this time?
Thank you. Thank you so much to Anastasia Dodson for putting in the chat the kind of the openness of different ideas for the 2024 DSNP contract. And this is a great opportunity for any and all of you to be part of the DSNP MLTSS work group. And if those acronyms are new to you, we'll make sure that that you get connected with those. There's a website associated with all of this. Our focus is to take that largest system approach and drive it back towards the person, which would be creating pilot opportunities to put the NCQA supported person-driven outcome measurement work into the DSNP pilots, into Medicare Advantage and other systems of care that put that person's voice really at the center point of care delivery. And I'll put a link in the chat about these measures, but I think there's opportunity for pilots to take value-based care to the next level and make sure that it really is person-centered inside these managed healthcare systems. And the state has a great opportunity in which to do that. Thank you.
Love it. Thank you so much. And Zia, to you.
Hi, Sarah. So I'm going to take a metaphor that Kim just used at a conference in Boston, and she used the word "and." I think what the state can really do well from their perch is facilitate the conversation when you think about age-friendly or age-inclusive, it's not just older adults, it's not just Medi-Cal, it's not just CMS and federal. If you do the right thing and if it's truly person-centered, then all of these populations benefit from it.
Mm-hmm.
I think from a healthcare system perspective, that's where I used to live, they also see it in that way. They are tired, like Laura said, of having too many things to be done. If we can help them understand to change the culture of care, to become truly person-centered, then you can address equity, you can address diversity of populations and different needs, but then to incentivize them to do that. So I love that concept of what you do right for the older adult is also right for somebody who's 55 or 40 and has those needs and can be met.
Great. Wonderful. Thank you so much, Zia. And Laura, Dr. Mosqueda, you finish up the panel conversation.
All right. Well, I think our huge opportunity is to connect the dots and make a really pretty picture that serves everybody well. And I'm just so excited about this time in California right now. I think we've got everything going in our favor. We've got a great Department of Aging going. We have a governor who's interested in this. We have funding. We have a legislature that's aligned with what the governor thinks. We have advocates. We have private foundations that are willing to fund this. If we don't grab this opportunity now, I don't know when we're going to have a better chance. And the big three areas I wrote down when you asked the question were workforce, training, and payment. And of course, those cross into a whole variety of areas. So those are my thoughts, Sarah.
Wonderful. Well, thank you all. What an amazing panel and lineup of speakers. I've certainly found it very helpful in understanding the broader system issues, but also what are some of the specific policy concepts that we can think about here at the state level and continue this conversation. Obviously, we're at the very beginning of our implementation of the master plan, so we will continue to call on all of you as our critical partners to help us think through all of this. So I would like to thank everybody for joining us and see Nancy is there. I want to encourage you to join us for our upcoming webinars. Next month is on Alzheimer's and dementia in focus. And then we have several others that you can see up on the screen. Again, very important opportunities to have your voice heard on these issues. One thing I did want to note too is that on September 20th of this year, we are going to have a really important in-person convening here in Sacramento. Really appreciate the support of all the Master Plan for Aging Foundation partners who are supporting this event. We're calling it the California for All Ages and Abilities Day of Action, where we're going to reimagine equity, aging, and disability and have you as part of it. And it's essentially almost a convention of sorts where we're going to be turning to all of our stakeholder advisory committees to provide their input and their platforms for policy initiatives for us to consider in the next phase of the master plan. So just a really great opportunity. We would love to see you all there and just look for more information on that. And then, of course, you can go to our Cal HHS MPA webpage or the CDA homepage for the full webinar schedule, and everything will be up and available at that webpage in the next few days. So with that, I think we are finished. And I just want to say again, a tremendous thank you to all of our panelists and to the Commission on Aging for sponsoring this event. So thank you all. Have a wonderful day.